Hello, everybody. My name is Mistry. I'm a general dentist from Toronto, Canada, and I'm here today to talk to you about some preventive dentistry. I have traveled to Uganda 3 times in the past. Twice I volunteered in the field with Kihefo, and once I came to Kampala to lecture in the symposium. A little background about me, my dad was actually born in Uganda in Kampala, and then I was born and raised in Canada, and it's an honor to be a volunteer here with you today through Build Your Smile Dental Foundation, and I really look forward to coming back to Uganda soon. So just to start, we'll be talking about the epidemiology of caries to start with, how it forms, what it is. Then we'll look at a caries risk assessment, a couple of different tools to assess what level of risk your patient is at. Then we'll talk a bit about preventive treatment planning, what things we should look at to help stop this disease. And then finally, we'll focus on a little bit of a diet analysis. So the epidemiology of caries, I just wanted to go over 2 quick studies. One was from 2015. It was cross-sectional, looking at the prevalence of caries in both children and adults in rural Uganda. And the overall DMFT scores were lower in children and much higher in adults. They were both significant in both rural and urban areas. And most of the people were brushing their teeth or cleaning their teeth somehow, whether with a plastic toothbrush or a stick. Now, a more recent study looking at the prevalence of caries in 2 cities looked at younger children, 11 to 19, and a smaller sample, but the DMFT score was quite higher. Now, one thing I do want to emphasize for everyone to appreciate is that the DMFT score is a cumulative score. So if you have cavities as a child, it's just going to get greater and greater as you become an adult. And that is why the burden of caries is significantly higher in adults. And we want to start educating our patients on how to stop this disease process and not just doing fillings over and over, because a filling, I tell my patients, it's just a Band-Aid solution. I'm fixing the cavitation in your tooth, but now we need to stop this disease process from affecting the other teeth. So that's a little bit about what we're going to discuss today. In order to prevent them, we have to understand how they occur. And I think we all have a general understanding of the multifactorial nature of caries. You need the right bacteria present. We know Strep mutans is the main cause of cavities. The diet, we know a diet high in sugar is going to lead to more cavities. And obviously we need the tooth structure present. Now, caries occurs over time, and that's very important to understand, is that even with these 3 factors present, the caries process is an equilibrium between remineralizing the tooth structure and demineralizing the tooth structure. The critical pH of enamel is 5.5. So at this pH level, the tooth will start to demineralize. And when the pH is less than 5.5, the caries process continues. Saliva is stimulated and it has buffering capacity to neutralize the acid, increase the pH above 5.5, and start the remineralization process. And so time is a very critical factor in the caries process, because if we can minimize the amount of time under the pH of 5.5, we can significantly reduce the rate of caries progression. So looking at this tool from the American Academy of Pediatric Dentistry, we're looking at a caries risk assessment for very young children. Now, the main things I want to highlight are things that would put them in the high risk zone. So that's if a primary caregiver has active caries. And this is because we know that caries is a transmissible infectious disease driven by bacteria. So the bacteria from the mother can actually be passed down to the child. And some of the other factors are low socioeconomic status. People with a lower dental knowledge tend to be at higher risk. And also, if the child has sugar in their diet, if they're put to bed with a bottle containing milk or juice, or if they have sugar containing snacks. The other main category that will put a child in the high risk zone is if they have active decay already or incipient decay. If you see any of these factors, you want to keep the child on a much closer recall frequency. So if a child is low risk, it's okay to see them once or twice a year. X-rays are typically indicated when they're old enough to bite onto a sensor, or if you suspect cavities, you can take an X-ray as long as the child can hold still. Now, moderate risk children are the ones with plaque visible along the gum line, children who you see, they may not be compliant brushing their teeth very well. You do want to see them still twice a year. But in addition, you want to apply topical fluoride. Age 3 is a little young to apply topical fluoride. We typically start at 3 minimum, and you want to try and apply it to all the surfaces twice a year when they come in for their dental visit. The main difference for children in the high risk category is how you approach them from a restorative standpoint. If you see any sign of incipient decay in a child with a high risk for cavities, you would be more inclined to go in and treat that at the early stage of decay and not wait for an actual cavitation. We know that caries can exist in different layers of the tooth, whether it's just in enamel or it's progressed into dentin or closing in on the pulp. So for very young children, any sign of incipient decay, you do want to go in and treat that sooner because it will be easier to treat. And if they develop recurrent decay around that filling, it gives you a bit more space to go in a bit deeper before you have to hit the pulp. Now, for ages 6 and up, this is one of the tools used by the American Dental Association. And you can see there's a lot more factors involved. There's general health that plays a role. There's clinical conditions, there's diet. And I've highlighted the main ones again that would put a child or adult in the high risk category. You can see that if they take in sugary foods and drinks frequently throughout the day, in between meals, that puts them at high risk. If their caregiver or parent or other siblings up to the age of 14, if they have active caries, it puts them at high risk. Anybody with special healthcare needs, if they're younger than 14, they're put in high risk, mainly because they don't have the dexterity, the discipline to go in and clean their teeth regularly. Any patients who are undergoing cancer treatment are in high risk, primarily of the head and neck, because it can reduce their salivary flow. As you can see, the last one here is severe dry mouth down there, puts them in high risk because you don't have that neutralizing, buffering, protective factor that saliva brings. And then for ages 6 and up, any kind of decay, missing filled teeth within the past 3 years, when there's 3 or more of those, would put them in the high risk. So now factors lowering caries risk. We want to look at what can we do now if we establish somebody as high or moderate risk. What can we do to bring that lower? Main thing is plaque control, oral hygiene. You want to teach them how to brush properly, give them the right oral aids. Mechanical debridement or brushing, flossing is the best way to remove the bacterial biofilm, to stop the caries process. That comes hand in hand with patient education. If you tell them what they're doing that causes cavities, they can be more aware of what habits to change to reduce their caries risk and prevent cavities in the future. We know in children we can increase their fluoride exposure. It's not typically indicated for adults because the permanent teeth take a lot longer to decay. They have a thicker layer of enamel, and typically brushing twice a day and the fluoride in the drinking water is sufficient. But in an adult with high caries risk, you should definitely consider applying fluoride varnish twice a year as well. And then we can lower their caries risk by modifying their diet and their habits. So we'll look into the last two, the fluoride and the diet, in a bit more detail. So fluoride, how does it actually prevent dental caries? Fluoride actually helps remineralize the early incipient decay, and it does that by forming a precipitate on the layer of the tooth instead of the typical hydroxyapatite crystal. When fluoride deposits, it becomes a fluoroapatite, which is actually more resistant to that acid attack or the demineralization that occurs when the pH drops below 5.5. So fluoride over time, it can embed itself in the tooth structure and create a more resistant enamel layer. A lot of patients ask, is fluoride antibacterial? It's not in the typical sense of antibiotics. It's not bactericidal or bacteriostatic, but studies do show that fluoride reduces some of the bacteria's factors that help it adhere or stick to the tooth structure. And it also interferes with bacterial metabolism. So it's not able to ingest sugar as well and secrete that acid byproduct that causes cavities. So I did a little bit just looking very generally at the overall fluoride levels in Uganda. And on average, they're about 1 milligram per liter, which is considered safe. Anything above 1.5 milligram per liter is considered concerning, may contribute to fluorosis of the teeth. And some areas at higher elevations in the mountains can see higher fluoride levels in Uganda. So it's important to understand the fluoride present in the drinking water of whatever community you're working in. So now diet is the most easily modifiable factor in the caries process between, the tooth, the bacteria, and the diet. The diet is the easiest to modify. So it's important to understand diet's multifactorial. You want to look at it from an overall health standpoint, but also from a caries risk standpoint. There's different types of foods. There's carbs, meats, fruits, vegetables, your dairy. Within the carbohydrates, which are the sugars, there's different types of sugars. There's your free sugars or your added sugars like candies, honey, whatever sugar substitute you might use. Or there's these complex sugars that are found in high starch foods like potatoes, rice, or bread. In addition to the amount of food someone ingests, it's also important to understand the frequency. Are they eating 3 sound meals a day, or are they snacking all throughout the day? And if you understand the etiology of caries and how it forms, you'll understand how an increased frequency of sugar intake can put someone at a higher risk for cavities, because the more sugar you take in at the more frequent times, you're going to have the pH dropping below 5.5 more often. And it takes the saliva at least about 20 to 30 minutes, depending on the person and what they're eating. It takes the saliva about 20, 30 minutes to neutralize the acid. So if somebody is having one chocolate every hour throughout the day, you can see how that would keep the pH of their saliva at a lower point than if they were to have their meal, have a piece of chocolate, and then not eat anything again until their next meal. So another thing to understand is certain sweet foods will stick to the teeth for longer, such as gummy candies. They tend to get stuck in the embrasure spaces or the crevices on the tops or between the teeth. And this can result in a longer sustained drop in pH compared to things like fruits, which are acidic. They stimulate strong salivary flow, which tends to neutralize the acids quicker. Now, globally, the WHO does recommend a diet high in starchy staple foods like rices, breads, potatoes, fruits, and vegetables as well, and low in free sugars. So it's safe to say that overall, for a patient's overall health, this is a good balanced diet to follow, and their free sugar intake should not be a significant part of their overall health, of their overall diet. So, how does this translate into practice? I just wanted to share some common questions that I ask my patients when I diagnose cavities. I never leave it at that. After I tell them, you have a cavity, I explain whether it's a new cavity or is it an old filling that now has a new cavity around it. And then I ask my patient, are you a sweet tooth? And they'll either laugh and say, oh, yes, I am. And, patients will understand for the most part that sugar causes cavities. If they don't, if they're not quick to admit to being a sweet tooth, I ask things like, oh, what's your favorite snack? What's your go-to snack? Do you snack often? And try and get a sense of what they're eating. Sometimes patients admit to snacking on dried fruits, which I find are really sticky, really sugary. Even though they're healthy, they have great nutrients in them, they tend to stick to teeth a lot more. I had a patient who snacked on dates, and we had to work it into her diet. I told her to eat it during her meals and explain to her how they're very sticky. So she was more aware of picking them all out between her teeth after eating them. You want to ask patients, do you eat anything sweet right before going to bed? A lot of patients will like having dessert, maybe a scoop of ice cream or something like that, very sugary, right before bed. And you want to explain to them how any sugar that they put in their mouth before bed, if they don't get it all out, it's going to sit there on their teeth all night long. When you're sleeping, your saliva flow decreases and you're at higher risk for cavities because the sugars that are left on your tooth will have all night long to contribute to the cavities. Another good question is, do you sip on sweetened beverages? Do they like coffee or tea, and do they put honey in it or sugar in it? Or do they like drinking soda? Some patients like lemon water, which is really acidic. It's not quite sugary, but the lemon is very acidic. And so that can help, that can lead to some tooth wear, which, we didn't get to touch on today, but that's another form of damage to the teeth. And you want to explain to patients if they do like their coffee or tea with a sugar or a honey, it's better to drink it within a short period of time, 15, 20 minutes, rinse your mouth out with water, and then not sip on it again or not drink something else sweet until your next meal. Once you kind of have an idea of their diet, then you also want to get an idea of their oral hygiene habits. Asking things like, how often do you brush? I never assume patients brush twice a day or know to brush twice a day. So asking open-ended questions, even starting with, do you brush your teeth? Or giving them a toothbrush and saying, show me how you brush, and improving their technique, making sure they get all the way to the distal of the upper molars and the buccal of the lower molars that are often hidden against the cheek. You can also ask, what kind of toothpaste do you use? Does it have fluoride in it? I'm not sure what's available in Uganda, but here a lot of patients are going all natural and they like fluoride free, which is fine, I tell them, if they're low caries risk. If they're high caries risk or if they have cavities, I tell them it's your choice. You can do what you want. But if you exclude fluoride in your toothpaste, you're not doing yourself any service, and we're not addressing the actual cause of your cavities, and this is going to continue. And you leave it to the patients to decide. They'll make an informed decision about their own health. The last thing I usually ask is, do you floss or clean somehow between your teeth? Because some patients like using soft picks, some patients like using floss, and it depends. If they have a lot of interproximal decay and they don't like flossing, I tell them brushing your teeth is not cleaning the area where you're getting cavities. Or if they only get occlusal caries, I don't usually emphasize the flossing as much. Occlusal caries tend to be associated with a lower risk for caries anyway. So once you kind of get all these questions answered, you can really sit back, look at your patient overall, consider their health, consider their oral hygiene, consider their diet, their caries risk, and put together a good recommendation going forward. I wanted to finish off by ending with this picture. This is Innocent and I at one of the uh, key hateful outreach sessions. This was back in 2017, I believe. And we conducted a large oral hygiene information, nutritional counseling session to a group of schools out in rural, I think it was near Kabale somewhere. And this is a very effective way to get the information out to a lot of people. We invited the teachers to also be present so that they could continue conveying this information to their future classes. And, I definitely think this is a really important part of our jobs. Diagnosing caries and treating caries is one thing, but if we don't change the patient's habits and diet, then we are not actually treating the cause or the source of the disease. So I hope this information was helpful to you. And if you have any questions, feel free to reach out to me, and I'll hope to see you all again soon. Thank you.